Good evening, and thank you for joining me on this talk on heel ulcers and calcaneal osteomyelitis. And greetings from Manchester in the United Kingdom. For all those of you dealing with diabetic patients, diabetic heel ulcers are a huge problem. The exact incidence of these heel ulcers is not known. It is believed that up to 20 to 30% of all the ulcers that you deal with in diabetic patients are likely to involve the calcaneum and the heel. As patients get older and also as they develop diabetes, the heel pad thins. And when you do get a heel ulcer, there can be direct spread of infection into the calcaneum, resulting in osteomyelitis, which complicates this condition. The heel itself is supplied by two arteries, the posterior tibial artery and also by the posterior branch of the peroneal artery. The blood supply to the heel comes from either side, which means that at the center of the heel, there is a relatively avascular zone which can be prone to breaking down. And also in individuals with poorer blood supply, this heel ulcer sometimes does not heal due to poor blood supply. Also, the heel is a very unique structure. The heel is designed to take weight and also to cushion us as we walk. So the heel is formed by various pockets of fat, almost avascular, which is held apart by fibrous septa, almost like little airbags in your heel. So when you do have a situation where you have infection in one of these pockets, it can either be isolated to that pocket or it can quickly spread to the rest of the heel, which also means that treating it becomes quite hard as your antibiotics may not have sufficient penetration in this area to treat the infection. Also, what is important here is to know the structure of the heel and the role that panniculus cavernosus plays. The panniculus cavernosus is a thin layer of muscle which is seen under the skin. It takes its name from the fact that it's seen in certain large mammals where you have the panniculus cavernosus throughout the body and is used by these animals to swat off flies when it sits on them. In the heel, the panniculus cavernosus is metabolically active, and it's believed that the panniculus cavernosus can get involved in the early stage of a heel ulcer. And it's believed that once the panniculus cavernosus gets damaged, whatever healing that you get does not really reform the structure of the heel, and that may be the reason that heel ulcers tend to form again and again and recur. The importance of the panniculus cavernosus is that since it's a thin layer of muscle, it tends to spread the load of the heel, protecting the heel from breaking down while weight bearing and walking. There are three types of heel ulcers that you have probably encountered and you need to be aware of. Zone 1 is the posterior decubitus ulcer, normally seen in patients where you have pressure areas and patients are immobile, and this is caused by direct loading while lying down and being immobile, and that can easily be avoided by offloading this area. The type 3 is a classic neuropathic heel ulcer, which you see in patients with neuropathic feet, insensate feet due to skin breakdown. And type 2 is the junctional one, which is a combination between the neuropathic ulcer and the decubitus ulcer. It's important to know what type of ulcer you're dealing with, because offloading or not bearing weight on the heel is important in type 3 ulcers, whereas in type 1 ulcers is to do mainly with the position of the foot and also ensuring that there's no heel pressure while lying down, etc. The importance of diabetic heel ulcers is that they are quite difficult to treat. These are some of my patients. As you can see, I'm sure that you've encountered similar patients in your practice. These ulcers are quite difficult and challenging to get to heal, and we know that they cost a lot more than ulcers anywhere else in the foot. That's partly because they involve the bone, you have early osteomyelitis, and skin coverage area can be a problem. In addition to the diabetic heel ulcer, you're also treating all these other conditions: neuropathy, patients on dialysis, poor compliance, immunosuppression, smokers, peripheral vascular disease, and increasingly an older aging population. Okay. Now, as in any other ulcer, the management of a diabetic foot infection should involve a multidisciplinary team. It's not something that you can do on your own. So treatment involves optimal diabetic control, effective local wound care. Then we come to the infection control aspect of things, where you want source control by debridement, and then you need to manage the dead space of whatever you've actually removed so that you don't get infection reforming again. In combination with this, you also need to have pressure relieving strategies and offloading, and also you need to restore the blood supply to the foot. The successful treatment would depend upon having a very holistic approach and an MDT approach to this. Several years ago, we published on our data regarding the management of heel ulcers by using a local antibiotic administered directly to the calcaneum after debridement of the heel ulcer. We call this a silo technique. I'm quite proud to say that this has now been adopted by various centers, and this is the go-to technique in the management of calcaneal osteomyelitis and also heel ulcers. The purpose of this talk is to take you through the technique so that you're aware of it, and I'm sure that many of you will have an interest in trying to adopt this technique in your patients. So the silo technique. The silo technique involves, when you have a heel ulcer, excising part of the calcaneum or the diseased bone. Remember, dead bone needs to be removed, but infected bone can be treated as anywhere else in the body. Now, what you do is that once the dead bone is removed from the heel, you drill channels into the calcaneum, and then you inject antibiotic into the bone directly, i.e. you're applying a local antibiotic to the area of infection so that it can work locally and have the best outcome and result by providing a very high concentration of antibiotic to the bone to treat it. Once the antibiotic has been applied, then you try and close the ulcer either by doing a primary closure or secondary intention, or by using a WAC, or if you've got access to plastic surgery, using a flap surgery. The holes themselves are normally non-geometric. You don't really want them to be in a pattern where it might cause the heel to fracture. You want it to be non-linear, as spread out as possible to involve the entire bone, and you really don't want to be penetrating any adjacent joints. So this is our technique, which we published about 5 years ago, which I will show you in a minute. You can see how the calcaneum has been debrided, the back of the infected bone has been removed, and we have injected antibiotic into holes in the calcaneum as silos, which tends to work quite locally. So here's your typical heel ulcer. You can see a fairly large area of ulceration, and you can see that's quite deep and is infected. These are the MRI scan images and the X-rays, which show breakdown in the skin, the ulcer, and involvement of the bone, especially the calcaneum, with osteomyelitis. You can see the problem where this patient has got a similar heel ulcer on the opposite side. So it's quite imperative that we try and save the foot and do not consider an amputation. So this is the heel ulcer once we start cleaning it. The same patient again. This is the process of cleaning it. Initially, all the slough and the dead skin has been removed, followed by more debridement down to the bleeding bone, followed by removal of the dead bone by doing a partial calcanectomy. You can see the picture on the left showing the excision line of the calcaneum, and the picture on the right, which shows what the foot looks like once the calcaneum has been taken off, followed by drilling holes in the calcaneum in a geometric manner so that you're not actually making linear holes which might fracture, followed by injection of antibiotic into these holes. So that's what the final product looks like once you're finished. And what do you think? Do you think it'll work? You can see the X-rays. That's the calcaneum being excised and injected with antibiotic. And you can see how the ulcer heals with time. So this is the same patient. About 6 months later, you can see how the ulcer is fully healed and the infection has been cleared. A similar sort of example, but on this occasion, after we did a calcanectomy, we managed to close the skin using some tension stitches so that we had primary closure on day 1. Occasionally, when you look at the heel, you may not be able to see your antibiotic, but we can be reassured the antibiotic is still working. So in this occasion, I took the patient back to theater and I had a look inside my cut to make sure the antibiotic was still there. And the antibiotic normally remains in place for up to 28 days working locally. So a question I often get asked is how much of the Achilles, how much of the calcaneum should you remove? And also what happens to the Achilles tendon? The answer to your question is that you need to remove as much of the infected bone as needed. As far as the Achilles is concerned, I am not too concerned about at this stage. This point, the important thing is to try and treat the infection and also to salvage the limb. You can see here that in this occasion, I have removed almost the entire calcaneum because it was diseased. And you can see how antibiotics injected into the bone after making drill holes. This is followed by the Achilles because it was detached completely, being inserted back into the talar body using some suture anchors, followed by a free flap to cover the gap. In this patient, you can see what you've done, a total calcanectomy, followed by a free flap and local antibiotic installation with Achilles tendon reattachment for a heel ulcer. The patient is put into a frame to offload the leg for a period of time till the flap heals. Similar sort of example, again, a large ulcer, a chronic ulcer. We have debrided this and we have used a local flap. Similar technique. Occasionally, as I said, because of where your hole placement and where your drill holes are in the calcaneum, you can get fractures. Like in this patient where I did a calcanectomy, unfortunately the calcaneum sustained a fracture, but it then went on to heal once the infection was cleared, and we had ulcer healing in about 4 months' time. Unfortunately, when you use a flap surgery, ulcers can break down again. In these circumstances, you need a good plastic surgical colleague if you really want to be able to cover these. Recently, we have also experimented with some regenerative technologies and PRP. So we recently published a paper on our experience using PRP clots. In this situation, what we do is that the heel ulcer is debrided. We do a silo technique for the osteomyelitis. And for the ulcer itself, we take platelet-rich plasma and we form that into a clot by activating it. And that's layered over the heel, like you can see on your picture on the right. The test tubes show the PRP which has been spun down, and the PRP is clotted into almost like a jelly. And the PRP clot is now applied over the ulcer itself, with the rest of the platelet-rich plasma being injected into the ulcer. And you can see the transformation over a period of several weeks. These are 2 such patients with healed heel ulcers after application of platelet-rich plasma clots. In future, we think that we may also be able to add antibiotic to platelet-rich plasma, which would be a game changer. So lastly, a partial calcanectomy is an excellent alternative for patients with heel ulcers and calcaneal osteomyelitis. The amount of heel resection depends upon the degree of osteomyelitis. Yes, in these patients, the strength of the posterior compartment muscles is reduced after excision of the calcaneum, but they tend to ambulate and walk reasonably well. In our series of patients, about 85% of patients maintain their ability to walk postoperatively. And definitely in older patients, we found that a partial calcanectomy offers better mobility compared to a below-knee amputation. If you're able to retain the Achilles, you get better outcomes. If you're not able to, it still doesn't mean that you get a very poor outcome. However, this is a difficult area to treat. And whatever you do, about a third of patients tend to have problems and may end up with a below-knee amputation. The surgical technique itself is very similar to what you normally would do for any ulcer. You want debridement, multiple tissue samples, all dead and necrotic tissue being removed, followed by injection of local antibiotic with a calcium sulfate carrier for dead space management. We use the silo technique for the hindfoot now routinely, and we use the same technique for the forefoot by injecting antibiotic into the intramedullary canal of the metatarsal bones. In summary, our cure rates using this technique has been almost 90% of infection clearance and 80% of ulcer healing. And this, I think, is comparable to non-diabetic patients. The hindfoot still continues to be a problem, but we feel that with meticulous technique and using local antibiotics and especially silo technique, you'll probably decrease your rate of amputation. We have published our study a few years ago, along with Alex V from Fernley Park, and finally, the silo technique. That's what I like to highlight today to you. Thank you and good evening.